GI pathology, cirrhosis, and portal hypertension. So let's get into the liver. Cirrhosis is just the diffuse fibrosis and regenerative nodules that disrupts the normal function of the liver. Okay, so that's what cirrhosis is. It's fibrosis and nodular parenchymal regenerative tissue or regeneration via the stellate cells. Remember, the stellate cells is very high yield and part in the pathophysiology of cirrhosis. Okay, now it can be caused by alcohol is the main part, but it can be also caused by non-alcoholic steatohepatitis, which is just fatty liver. You can be caused by viral hepatitis, by hepatitis B, A, C, all those. It could be caused by autoimmune hepatitis and a couple other things, but we're going to get into those pathologies later on. Now, cirrhosis can lead to portal hypertension, which is just increase in pressure in the portal venous system. All right, and once again, that's the most common pathology of portal hypertension is cirrhosis, but it can also be caused by vascular obstructions like portal vein thrombosis or Budd-Chiari syndrome, which we will discuss later on. Schistosomiasis can also lead to portal hypertension. So, next, cirrhosis leads to multiple pathologies that you need to know, and it's just like a classical presentation. The first thing you have to know is ascites. Cirrhosis can lead to portal hypertension, and portal hypertension leads to ascites because when you have an increase in pressure in the portal venous system, it leads to an increase in hydrostatic pressure, which pushes fluid out of the vasculature and into the extravascular space, which is just the abdominal cavity where ascites starts to build up. You also have an overall decrease in plasma oncotic pressure because the liver is failed, okay? So you have cirrhosis of the liver, so you have not really normal liver function. And normal liver function, what it normally does is going to produce like proteins like albumin, which helps keep our plasma oncotic pressure high. But without those proteins like albumin, you have a drop in plasma oncotic pressure, which also aids in the formation of ascites. Okay? So that's the first thing that you have to take away. The second thing, hyperammonemia. Okay, so you have an increase in ammonia in the blood. The reason behind this is because the liver is not doing a good job in functioning by clearing the blood that's coming from the GI tract. So you have an elevated amount of ammonia in the blood. The issue with this is that ammonia is toxic to the brain. So it can lead to hepatic encephalopathy, where the patient is like ANO times 1. They become very confused, completely disoriented, not alert anymore. And you could see this on physical exam with flapping of the hands, flapping tremor known as asterixis. A way that you could treat hyperammonemia is by two things. First one, lactulose. Lactulose is going to help trap ammonia in the stool, and essentially you're going to be pooping out all the ammonia. And that will decrease the total amount of ammonia being absorbed by the body. Another thing you could give them is rifaximin, which is an antibiotic that just kills off the ammonia-secreting bacteria or ammonia-creating bacteria. And so if you kill off the bacteria that makes ammonia, then you're going to have an overall decrease in ammonia reabsorption. Those are the two mechanisms that you can do to help curb the effects of hyperammonemia. Next is going to be elevated estrogen. So you have elevated estrogen levels in a cirrhotic patient, and that leads to three classical symptoms: gynecomastia, spider angiomatas, and palmar erythemas. And they want you to know those specific three are caused by elevated estrogen. They're going to give you a patient with a classical presentation of cirrhosis, and you're going to think, okay, and then the final question is going to ask you, well, which one has a very similar pathophysiology to spider angiomatas? And the answer is going to be palmar erythema or gyno, right? Because they all are due to the fact that it's increased estrogen that causes these, okay? Next, you're going to be seeing a lot of effects of portal hypertension like esophageal and gastric varices, which can lead to hematoemesis and melena, right? That can cause GI bleeding, which is very, very scary. It can cause congestion, so you're going to see splenomegaly in patients potentially, all right? And you can cause peripheral edema because of third spacing, right? And so that is another cause, which is known as vasodilation. So you can have vasodilation, which leads to decrease in blood pressure, but you're going to have an overall increase in total body water with an overall decrease in effective circulating volume. The reason you have a decrease in effective circulating volume, but an overall increase in total body volume is because all of that volume is going to be leaking out into the abdominal cavity, causing ascites. Okay, and that's very key to understanding one of the main symptoms, ascites, for cirrhosis. Okay. For ascites, they also want you to know that there's increased levels of ADH and patients will have decreased urine sodium. Okay. Something that you're just going to have to remember. Now, lastly, kind of the main takeaway of cirrhosis and portal hypertension. If you see a patient that comes in and they say, Doc, I've been rapidly gaining weight and my abdomen has been like rapidly increasing in size. They'll say like they've come to the hospital because of rapid increase in size of their abdomen. That's one major sign of cirrhosis. They're going to have like peripheral edema. Okay. And they're going to have a bunch of the signs that we just discussed. Start thinking about a patient with cirrhosis. Okay. They're probably going to give you their alcoholic history. They could be presenting already with some type of esophageal varices that have ruptured, and now they're having hematoemesis or melena, right? So these are the things you have to keep in mind when discussing cirrhosis. Don't forget the main pathophysiology behind it is due to stellate cells causing fibrosis and nodular parenchymal regeneration. All right, so that's all for cirrhosis.